everyone. It's nice to see Ajit sir here. It's going to be an excellent evening again. We are going to discuss andrology. This is Uromet 2.6. Bit of housekeeping again. There's going to be, actually it was planned to be 5 speakers. Now it will be 4 speakers. They have allocated that time, and after that we'll have discussion, probably some cases. To start the proceeding, the first talk is going to be on infertility and hypogonadism. It's going to be by Dr. Balakrishnan Pragalathan. You have 20 minutes. Over to you, Pragalathan.
Good evening, sir, and my colleagues. And today I'm going to talk on the male hypogonadism and the infertility. Some slides are not moving, sir.
Can you move the slides, Pragalathan, for us to check?
Yes, it's not moving, sir.
Okay.
Yeah. Now, okay, sir. Regarding the male hypogonadism, the male hypogonadism defined as a clinical syndrome caused by the androgen deficiency, which may be adversely affect the multiple organ function and the quality of life. The diagnosis of hypogonadism must comprise the both persistent clinical symptoms as well as the biochemical evidence of testosterone deficiency. So the androgen deficiency increases with the aging. So it's about in the instance in main age about 40 to 79 varies from the 2% to 6%. The hypogonadism is more prevalent in the older men and in men with obesity and those with the comorbidities. The androgens are needed for the puberty and the male fertility and the male sexual function and the muscle formation, bone mineralization, fat metabolism, and the cognitive function. There's something regarding that sexual development in the male. The male sexual development starts between the 7 to 12 weeks of gestation. So the fetal testes produce the testosterone, insulin-like peptides, and the anti-Mullerian hormone. Both 3 hormones are regulate the testicular adhesions, and the testosterone is needed for the stabilization of the Wolfram duct, result in the formation of the epidermis and the vas deferens and the seminal vesicle, as well as the formation of the penile growth and the activating the androgen receptors. The production of the testosterone is controlled by the in the fetus by the placental HCG and after birth by the LH from the pituitary glands. So immediately after the birth, the serum testosterone level reaches the adult concentration over several months. Then it's declined to lower level until the puberty. The classification of the hypogonadism has some therapeutic implications. So we can classify it according to the level of the disturbance. So primary hypogonadism at the level at the testis, and the secondary hypogonadism at the level of the hypothalamus and the pituitary. And the late onset or adult onset of hypogonadism can combine with the hypothalamus, pituitary, and the gonadal axis. And then lastly, that androgen receptor insensitivity or resistance. So the common causes for the primary hypogonadism are the well-descended ectopic testis or Klinefelter syndrome, the germ cell testicular tumors, and infection of the testis causing that hypogonadism, and other acute conditions causing the hypogonadism such as the trauma, tumor, torsion, and the inflammation, and the secondary testicular dysfunction due to the drugs or medication and the systemic disease and varicocele, and other idiopathic cause and other rare congenital conditions. The secondary hypogonadisms are commonly due to the pituitary adenoma, due to the mainly that hypoprolactinoma, and others idiopathic. Now it's called as a isolated hypogonadotrophic hypogonadism. The Hallman syndrome, where GnRH deficiency associated with the insomnia, and the secondary GnRH deficiency due to the medication, drugs, or toxins, and the systemic disease, and other rare conditions with the Prader-Willi syndrome and the congenital adrenal hyperplasia with the hypogonadotrophic hypogonadism. And the adult onset of hypogonadism, so where the diagnosis of functional hypogonadism is based on the exclusion of other organic causes. The main cause of the functional hypogonadism are obesity and comorbidities and the age. So where the inflammatory cytokines released from the chronic inflammation, and the adipocytokines and the estradiol in obesity cause suppression of the hypothalamo-pituitary gonadal axis. The male hypogonadism due to the defects in the androgen target organs, so the androgen receptor defects with the complete or partial with the minimal androgen sensitivity symptoms such as the Riefenstein syndrome, bulbospinal muscular dystrophy, and 5-alpha reductase deficiency. There's some physiology of the testosterone production where the pituitary releases the FSH and LH, which regulate the testicular function as which controlled by the negatively inhibited by the sex steroids and the inhibin, regulated by the pulsatory release of the GnRH from the hypothalamus. So normally about 25 milligram of testosterone is present in the normal testis. On average, about 5 to 10 milligram of testosterone are secreted daily. The diagnostic evaluations, mainly with the clinical symptoms suggestive of androgen deficiency, are the reduced testicular volume and the male factor infertility, decreased body hair, the gynecomastia, the decreased lean body mass and muscle strength, obesity, and the metabolic syndrome, the decreased bone mineral density causing the fractures, and the sexual symptoms such as the reduced sexual desire and the sexual activity, erectile dysfunction, and the fever, diminished nocturnal erection. And the cognitive symptoms such as the hot flushes, changes in mood, fatigue, anger, sleep disturbance, and the depression, and the diminished cognitive function. So usually about the testosterone level, less than 8 nanomillimole per to consider as a hypogonadism, or the serum testosterone range of 8 to 11 millimole nanomole per liter, and the free testosterone less than 220. And the laboratory testing of the testosterone should reflect that on the diurnal variation of testosterone. So in most cases, 2 morning, about 7 a.m. and the 11 a.m. samples are sufficient. In case with the discrepancy within the testosterone levels and the symptoms, free testosterone level should be analyzed. So to differentiate the between the primary and the secondary forms of hypogonadism, other hormone, the LH level should be checked. So both LH and the testosterone serum level should be analyzed twice within the 30 days, preferably in a fasting state. The clinical consequence of hypogonadism, so prenatal androgen deficiency, where the testosterone is crucial for the normal realization of the external male genitalia, result in a abnormal genital development ranging from the hypospadiasis to female external genitalia with the intra-abdominal testes. And the pre-pubertal onset of androgen deficiency during the puberty, rising testosterone level result in a development of male secondary sexual characteristic. So signs and symptoms are the delayed puberty, small testes and cryptorchidism, the gynecomastia, high-pitched voice, and close epiphysis lead to the linear growth in the adulthood, and the sparse body hair, and the low bone mass. The late onset of hypogonadism, defined as a testosterone deficiency, usually associated with the clinical symptoms and signs in a person who had a normal pubertal development with the normal secondary sexual characteristic. Signs and symptoms are the loss of libido, erectile dysfunction, decreasing morning erection, obesity and the low bone mass, depression, and the hot flashes. So the management is a main aim to restore the physiological androgen dependent function and improve the quality of life. So the main indication for the testosterone treatments are the delayed puberty and the Klinefelter syndrome with the hypogonadism, the sexual dysfunction and the low testosterone not respond in the PDEF5, and the low bone mass in the hypogonadism and the hypopituitarism. And the contraindication against the testosterone are mainly the locally advanced or the metastatic prostate cancer, male breast cancer, so men with the active desire to have a children, and the hematocrit more than 0.54, and the severe chronic cardiac failure. So benefits of treatment. So in congenital hypogonadotrophic hypogonadism, treatment is usually indicated where the hormonal stimulation with the HCG and the FSH, or alternative with the pulsatile GnRH, can induce the puberty as well as the restore the fertility in most cases and normalize the bone mineralization. In adult onset of hypogonadism, testosterone treatment may improve the symptoms, and testosterone therapy was shown to moderately increase the sexual function in the hypogonadal man. The testosterone treatment can improve the body composition, bone mineralization, signs of metabolic syndrome, male sexual problems, and the diabetes regulation, and the memory and the depressive symptoms. Choice of treatment, there are several preparations are available which define the route of administration and the pharmacokinetic as well as the adverse effects. So the choice selection should be joint decision by both patient and the physician. There are for a short acting preparation are preferred to the long acting in the initial treatment phase, and there are commonly used the testosterone anticonate, usually the oral delivery system, and also having a long-acting intramuscular injection. So the common adverse effects lead to the increase in hematocrit and increase in the prostate-specific antigen and injection side effect. There are other intramuscular drugs are available, the testosterone cypionate and the enthin. And there are transdermal testosterone preparation available in a 1 to 2% gel form. They provide the uniform in the normal serum testosterone level for 24 hours. And they are using that enclofumin citrate, but it's a now it's a off-label medication for the male hypogonadism. So these are the common testosterone treatment availability for a hypogonadism. EAU recommend the follow-up to usually that assessment need in a 3, 6, and 12 months, and then annually for the testosterone treatment, and then monitor the testosterone and the hematocrit in a 3, 6, and 12 months, then thereafter annually. So if it is increasing in a hematocrit, where we can switch to the other testosterone preparation. If it is persistently elevated, we can stop, and we can after reducing level, then we can restart. And we need to do the digital examination as well as the PSA in a 3, 6, 12 month and annually. So assess the men with the cardiovascular disease for the cardiovascular symptoms before the testosterone treatment is initiated, and continue the close clinical assessment during the treatment. So my next topic is the male infertility is defined as the inability of sexual active and non-contraceptive couple to achieve the spontaneous pregnancy within the 1 year. So about 15% of the couples do not achieve the pregnancy within the 1 year and seek a medical treatment for infertility. So the unexplained male infertility defined as unknown origin of with the normal sperm parameters and partner evaluation. Between 20 to 30% of the couple will have an unexplained infertility. So the common causes are the multicentric testis, varicocele, sperm autoantibodies, testicular tumor, idiopathic, and the causes of hypogonadism, and other disturbance of erection or ejaculation due to the obstruction or vasectomy, and the cystic fibrosis. The diagnosis with the history, we need to ask about the reproductive history, about the pre-conception or contraception, partner's age, and the female factor evaluation, and the frequency and the timing of intercourse, and family history of infertility, libido, erectile function, ejaculatory difficulty. The past medical history asks about the cancer and the treatment, sexual transmitted disease, torsion and trauma, and past surgical history about inguinal hernia repair, vasectomy, pelvic surgery, and orchidopexy. The medication about the androgen, immunosuppression, and the chemotherapy, and ask about the social history, mainly the smoking and alcohol. And the physical examination mainly check for the height and the BMI, and the secondary sexual characteristic and the gynecomastia. The scrotal examination assess the testis size and the symmetry and the consistency, and the presence of vas difference, full of epididymis, and the presence of varicocele, and the abnormalities of penis, such as phimosis, frenulum, fibrotic nodules, and epispadias. The semen then do the semen analysis according to the WHO manual 6th edition. The semen examination divided into 3 chapters. The basic examination we are check for this sperm numbers, mortality, and the morphology. And the extended examination we are detect the leukocytes and the markers of genital tract inflammation, the sperm antibodies, and the DNA fragmentation index. The advanced examination mainly assess the reactive oxygen species and the oxidative stress and the membrane ion channels. This is the lower reference limit of the semen characteristic, where the semen volume considers that low volume when the less than 1.4, and the total sperm number when less than 39 million, and the total motility less than 42%. Then the sperm morphology when less than 4%, and the leukocytes counts should be less than 1 million per ml. So if the semen analysis is normal according to the WHO criteria, the single test is sufficient. If the result is abnormal, so at least 2 tests needed. The further embryological investigation is indicated. When the definition of oligozoospermia considered is less than 15 million of spermatozoa per ml. The asthenozoospermia less than 32% of progressive motile spermatozoa. The keratozoospermia is less than 4% of normal forms. And the leukocytospermia more than 1 million of WBC per ml. So the measurements of sperm DNA fragmentation index, the sperm DNA damage is more common in infertile men, has been a major contributor to the male infertility, as well as the poor outcomes following the artificial reproductive technology. And the sperm DNA damage increase the hormonal anomalies, varicocele, chronic infection, and the lifestyle factors. And the testicular sperm is reported to have a lower levels of sperm DNA fragmentation index when compared to the ejaculated sperm. The hormonal determination to mainly detect the hypogonadism, do the testosterone, FSH, LH, and also the prolactin. So genetic testing, so the incidence of chromosomal anomalies was about 6%. So mainly the sex chromosome is about the 5%, and mainly the Klinefelter syndrome, where the 47XS5 is the most common sex chromosomal abnormality. And the autosomal abnormality, there are the Robertsonian translocation or reciprocal translocation and other abnormalities can be there. When the structural abnormalities of the vast different detected should be due the cystic fibrosis gene mutation, and the Y microdeletion partial or complete. The high frequency of Y deletion is found in an azoospermic man, followed by the oligosperm. And the sperm chromosomal abnormality mainly due for an aneuploidy in a sperm. So this is the EAU guidelines for the karyotype analysis. Offer the standard karyotype analysis and genetic counseling to all men with the azoospermia and oligozoospermia for the diagnostic purpose. The Y chromosome microdeletion testing may be offered to men with a sperm concentration less than 5 million. It must mandatory in men with the sperm concentration less than 1 million per sperm in M. So in men with the structural abnormalities of the breast, the test the man and his partner for the cystic fibrosis transmembrane conductance regulator gene mutation, and perform the sperm DNA fragmentation testing in the assessment of couples with the recurrent pregnancy loss from the natural conception and the ART or men with the unexplained infertility. The measurement of oxidative stress, and the oxidative stress may lead to the sperm DNA damage and poor DNA integrity, which are associated with the poor embryo development, miscarriage, and the infertility. The oxidative stress is generally associated with the poor lifestyles and the environmental exposure. Therefore, the antioxidant regimes and the lifestyle intervention may reduce the risk of DNA fragmentation and improve the sperm quality. So, imaging in the infertile men, doing a scrotal
You have 5 minutes.
Doing a scrotal ultrasound scan, we can measure the testicular volume, assess the testicular anatomy and the structure, detect the testicular tumor and the indirect signs of obstruction. And doing the transrectal ultrasound scan, so mainly assessing in obstructive azoospermia to look for ejaculatory duct cyst and the seminal vesicular dilatation and the hypoplasia or atrophy. So common conditions associated with the male infertility, cryptorchidism. So 1 year of age, nearly 1% all full-term male infants have a cryptorchidism. Approximately 30% of undescended testes are non-palpable and may be located within the abdominal cavity. So it can be linked with the maternal gestation, smoking, and the premature birth. So during the second year, the number of germ cell declines, so which lead to the infertility. So to prevent that, we need the early correction. So usually we are here doing within the 6 to 12 months of year. The men with the unilateral cryptocurrency paternity is almost equal to that in men with the without cryptocurrency. In case with the bilateral cryptocurrency, the rate of paternity falls to about less than 50%. The management, so orchidopexy may be offered to preserve the androgen production in fertility. So correction of bilateral cryptocurrency even in the adulthood can lead to the sperm production in previously azoospermic men, and therefore may be considered in this patient or in patient who please have high value in fertility preservation. The germ cell malignancy and the male infertility is about affects approximately 1% of the subfertile men. The azoospermia has been observed in a 5 to 8% men with the germ cell tumor and oligospermia in 50%. The treatment of germ cell tumor can result in additional impairment of semen quality and the increased sperm aneuploidy up to 2 years following the gonadotoxic therapy. So they perform the sperm cryopreservation prior to the planned orchidectomy or before the addition of neoadjuvant or adjuvant oncological therapy, since the men with the testis cancer may have a significant semen abnormality. They offer the oncotesticular sperm extraction at the time of the radical orchidectomy to men with the testicular cancer and azoospermia or severe abnormalities in their semen parameters. Varicocele, so it's usually associated with the male subfertility and the failure of selective testicular growth and development, pain, and the discomfort and hypogonadism. We can classify into the subclinical. We are only detected with the special test. The Doppler ultrasound scan, grade 1 is palpable during the Valsalva maneuver, grade 2 is palpable at rest, and the grade 3 visible and the palpable at rest. So the maximum venous diameter of more than 3 millimeter in the upright and the Valsalva maneuver, and the venous reflux with the duration of more than 2 seconds correlate with the presence of clinically significant varicose. So varicocele present in almost 15% of the normal male population, in 25% men with the abnormal semen analysis, and 35 to 40% is men presenting with the infertility. So due to the increased cortical temperature, hypoxia, and the reflux of toxic metabolite can cause the testicular dysfunction and infertility due to the overall survival and DNA damage. So meta-analysis, Hogrand meta-analysis show that the improvement in semen parameters are usually observed after the surgical correction in men with abnormal parameters. So now increasing evidence that the varicocele treatment may improve the DNA fragmentation and outcomes from the AR. The current evidence that indicates the microsurgical varicocelectomy is the most effective among the different varicocelectomy techniques. These are the multiple treatment available for the varicocele, such as the sclerotherapy with the anticrate or retrograde, and the retrograde embolization, and the open or laparoscopic approach. And the microsurgical inguinal or subinguinal is the standard treatment. The male accessory gland infection and the infertility is a WHO considered urethritis and the prostatitis, orchitis, and epidermitis as a magis, and after exclusion of UTI. So more than 1 million of WGVC in ML indicate an inflammatory process. So in the case that we can go for a semen culture, the PCR analysis should be performed, and in HPV the semen range from the 2 to 30% in the general population, and in the high in men with the unexplained infertility. The seminal presence of HSV2 in infertile men may have associated with the lower sperm quality. Although antibiotic treatment and the magis may result in an improvement of sperm quality, does not enhance the probability of conception. There are data not insufficient to conclude whether the antibiotic and antioxidant for the treatment of infertile men with the leukocytospermia improve the fertility outcomes. So the non-invasive male infertility management. So the mainly that lifestyle modification with the weight loss, physical activity, smoking cessation, and the reduced alcohol intake. And there is no evidence suggest for the oxidative antioxidant. And there are some studies says that selective estrogen receptor modulators having some positive result, and also the aromatase inhibitors. And the patient who are with the hypogonadotrophic hypogonadism, including the congenital cause, we can combine with the SCGN, FSH, or pulsed GnRH via the pump therapy to stimulate the spermatogenesis. So the invasive male fertility management, so the in obstructive azoospermia, so it accounts about the 20 to 40% of the men with the azoospermia usually have a normal FSH and the testis in normal size and epidermal enlargement. It can be from the intratesticular obstruction. It's about 15% with the obstructed azoospermia. Can be due to the post-surgical iatrogenic obstruction following hydrocelectomy or the scrotal surgery, or post-traumatic or post-ocean. The epididymal obstruction is most common cause of the obstructive azoospermia, affecting about 30 to 70%, and it can be due to the infection, the trauma, or post-surgical iatrogenic obstruction during hydrocelectomy or the scrotal surgery, can be congenital. The vast difference obstruction is a post-surgical due to the post-surgical obstruction following herniotrophy or the scrotal surgery or reversion of vasectomy, and the congenital unilateral or bilateral absence of vas due to the associated with the cystic fibrosis. And the ejaculatory duct obstruction, found in about 1 to 5% of the cases, can be due to the cyst, Mullerian, jutricular, the prostatic or seminal-vesicular, can be due to the infection, traumatic, and post-surgical obstruction. And finally, the functional obstruction due to the idiopathic or local neurogenic dysfunction. The disease management, mainly the sperm retrieval, we can go with the, for the testicular obstruction, we can go with the testicular sperm extraction. And for the epididymal obstruction, we can go with the microsurgical epididymal sperm aspiration or percutaneous aspiration. For the vast difference obstruction, we can go with the microsurgical vasectomy or testicular extraction of the sperm. And if it is ejaculatory duct obstruction, we can go with the transurethral resection of the ejaculatory duct. Or if it is cyst causing the obstruction, we can go with the incision or unroofing or aspiration of the cyst. If it is calculus causing the obstruction, we can go with the seminal vesiculoscopy to remove the debris or calculus, or we can go with the balloon dilatation. For patients who are with the non-obstructive azoospermia, the often consequence of primary testicular dysfunction may be related to the dysfunction of the hypothalamus-pituitary-gonadal axis. So the investigation that we can go with the detailed medical history to look for a history of preecocardism, previous nodotoxic treatment, and the genetic test, and the hormonal investigation to explore the concomitant hypogonadism in the scrotal ultrasound scan. So the surgery for the non-obstructive azoospermia, so they aim at the retrieval of vital sperm directly from the testis, normally part of the ART protocols, including the IVF and the ICS. The surgical techniques, we can go with the testicular sperm aspiration or the single or multiple conventional testicular extraction of sperm. So assisted reproductive technologies, the type of assisted technologies are the intrauterine insemination. So the global pregnancy and the delivery rate for the IUI is about 12 and 8%. The IUI is not recommended in couple with the unexplained infertility and the male factor infertility. And the IUI with the ovarian stimulation is a safer and the cheaper and more patient friendly and the non-inferior alternative to the IVF in the management of couples with the unexplained and the mild male factor infertility. The in vitro fertilization and the global pregnancy rate and the delivery rate per aspiration of non-donor IVF is about the 24 and the 70. The intracytoplasmic sperm injection, currently the most commonly used assisted reproductive technology, they account for about 70 to 80%, and the fertilization after the ICA is about 70 to 80%, and the clinical pregnancy rate up to 50%. These are the common fertilization method associated with the male factor. The male for the male factor infertility, they advise to go with the intracytoplasmic sperm injection. Thanks.
Thank you, Pragaladan, for nice presentation. We'll next move to the next presentation on erectile dysfunction. It will be done by Dr. Neranga Samarasinghe. Yes.
Shall we discuss this with the expert?
Okay.
Ajit sir?
Yes, hello. Yeah, I think it's best to sort of discuss a little bit and then move on to the next section, isn't it? Rather than, yes, very comprehensive presentation that you made. My personal view is that, I mean, you took us through the entire EAU guidelines for male hypogonadism and essentially infertility. I think what I just suggest, I don't know the views of the others, but what you should do is to take the most important things out of that and make a very concise presentation so that we learn what is really important out of that. It's very good if you can retain all of these for the exam and also for your day-to-day practice. But what the essential core of things, you must try and shrink it down and present it in a very concise manner. But anyway, congratulations, a nice presentation. Just a few things that questions in my mind. So infertility patients, when you're dealing with them, a lot of them come with azoospermia. So how do you deal with 27-year-old man who comes 4 years, they've been trying for a kid and they present to a gynecologist who does a SFA, and then you find that there is azoospermia. Walk me through all the data that you presented and how you apply that data to this patient and how you manage that patient. What are the thought processes that go through your mind?
Yes, after the first I will go through the patient history. Maybe the history I will ask about the reproductive history, about that any conception, any use of contraception, and the frequency of sexual intercourse and the timing, as well as any investigated for the female about the female partner, and possible comorbidities. Ask about that any other drugs he has taken, mainly that any sex steroids and any external androgens. And past surgical history, mainly look for any evidence of any he has underwent any testing, cryptogorgism, any undescended for the orchidopexy for the undescended testes, or any associated with the hypospadiasis and other things. So after that, I will mainly focus on the social history of that smoking as well as the alcohol intake history. So then I will go through that any associated family history. So after that, then mainly look for the examination, look for any evidence of secondary sexual characteristic, as well as assess the testis, mainly look for the size and the texture of the testis and associated penile and other.
So what are the diagnoses that you have at the background? I told you that this patient is azoospermic. So what are the diagnoses that you are thinking of?
It can be obstructive azoospermia or the non-obstructive.
Okay.
The obstructive azoospermia, it can be due to that previously at the testicular level, or it may be in the epidermal level or the vas level. So in the ask about that, to look for any previous epidermal gastritis or any abnormal in the vas.
So in the examination, you need to examine for the vas. Anything about the patient, the general disposition of the patient.
Any associated syndrome, so the Klinefelter syndrome.
So what are the syndrome features that you look for in a patient like this? Klinefelters, what is the characteristic phenotype that you see in a patient?
Yeah, it can be associated with the 47 XS5 or the other patient with the 46 XS.
Now the phenotype, that's the genotype and the karyotype we're talking about. No? The phenotype is what the patient looks like.
Yes, sir.
What are the things? Yeah.
Usually with the tall guy with the thin.
Yeah. Okay, the tall stature, those are the features that you look for, isn't it? Yeah. Then investigations wise, so you have the seminal fluid analysis to differentiate obstructive versus non-obstructive. What are the things that can help you?
Yes, and the obstructive, it's this. We don't see the sperm counts that less than total number is there, so, but the sperm number of sperms is less. Oligospermia.
No, this is a azoospermic chap, no? you are trying to differentiate between non-obstructive versus obstructive. So they are both azoospermic. Huh?
Yeah.
What are the things that you look for? How do you differentiate the non-obstructive versus obstructive? So you have to go through the parameters. No, what do you think about the volume?
So volume should be less than 1.4 milliliters.
So to differentiate between obstructive and a non-obstructive patient, what are the differences? Are there differences in the volume? There are differences in the pH? Are there differences sometimes in the fructose?
Usually the differences in the volume as well as the concentration and for the obstructive.
I don't think you have got my question here. Anybody else that can answer that?
Hello, sir.
Any trainees can answer this question?
Yeah.
Hello.
Yes, go ahead. Go ahead.
In the azoospermia, when there's obstructive, there will be absent the volume absent or minimal volume.
Yes, that's right. Volume, yes, absolutely, you're correct. The volume is very much lower in the obstructive azoospermia. Then what else? What about the pH?
The pH was alkaline pH towards because the pH pH don't remember.
Normally it's what? Normally the pH is in what ranges? What alkaline? No, yeah. I mean about 8 or so that you see, in a normal SFA. Yeah. In obstructive one, what do you find generally? It swings more towards the other side, isn't it? More acidic.
Yeah.
Yes, that's right. Yeah. And what is the significance of looking at fructose? What can you say? Presence or absence of fructose? What will it tell us?
Absence of fructose tell us about the production because the seminal fluid is coming from the prostate secretion seminal fluid.
Yeah.
Also,
right, yeah. So if it is absent, not found in the seminal fluid, what will you think of it?
Then it's a thinking of obstructive, the fructose is absent. We have to think about the obstructive type rather than the non-obstructive type.
And also the site of obstruction.
Site of obstruction also we have some.
Yeah. I mean, if it's a testicular or epididymal obstruction, still you will have fructose coming into the seminal fluid. No? Yeah. Okay. Yeah. So some. Right. So just wanted to stimulate you all on. The EAU guidelines are fine, but you need to be able to pull out these facts and look at a patient and apply this knowledge and decipher the problem which is there at the back of this patient. So right. I think we may be running out of time, no? So let's
yes. Next presentation is the erectile dysfunction, which will be done by Dr. Neranga Samarasinghe. Dr. Neranga, over to you.
Okay, sir. Hello, sir. Can you see my presentation, sir?
Yes, we can see. We can see the slide view, but not the presentation. If it is not working, just continue with this current.
Okay. Now,
now okay. Yeah.
Okay, sir. The topic is the management of erectile dysfunction. I'm Dr. Samar Singh from NHSL. So regarding the definition of the erectile dysfunction, it's defined as a persistent inability to attain and maintain sufficient erection for a for a satisfactory sexual performance. So it's a variable definition, and this erectile dysfunction itself increases the risk of future cardiovascular events, including the myocardial infarction, cerebrovascular events, and all-cause mortality, with a trend toward increased risk of cardiovascular mortality. The erectile dysfunction can be commonly classified in three groups based on etiology: the organic, psychogenic, and mixed group. This organic group include this vascular causes, and then ENS causes, and neuropathy include causes. The neuropathic causes can be central and peripheral.
Ranga, we can't hear you.
Hello, sir. The slides are not moving.
Ah,
Okay, sir. Now it's moving. Then we can consider the risk factors. Can you hear me, sir?
yes, we can.
Okay. The consider risk factors, we can consider the increase in age, diabetes mellitus, dyslipidemia, hypertension, as we discussed, cerebrovascular diseases, patients' BMI, obesity, and waist circumference, and metabolic syndrome, and many lack of exercise and smoking. And there's a well-known relation between the cigarette smoking, even with these electronic nicotine delivering devices. There's a clear demonstrated positive dose response association between the quantity and the duration of smoking with erectile dysfunction. And new research, there are evidence regarding the association in between reasons of COVID-19 infection and relation with erectile dysfunction as well. And there are association between the lower tract symptoms, BPH, and sexual dysfunction with erectile dysfunction regardless of their age. If we consider the surgeries, especially for BPH and LUTS, when there's a TURP using the laser, open or laparoscopic technique, if the patient is having this chronic prostatitis or chronic pelvic pain syndrome, and when there's interstitial cystitis, and uretroplasty surgery done for these posterior strictures, they are association with this erectile dysfunction. When we come to the urological practice, main concern is this pelvic surgery and prostate cancer treatment related erectile dysfunction. This mainly occur when we have done pelvic surgery for these oncological diseases, including radical prostatectomy and cystectomy. The most relevant causal factor is the lesion occurring in this neurovascular bundle that have a complex mechanism of this cavernous erectile response, whose preservation goes to this the technique of this nerve sparing technique. If we consider the evidence, this PROTECT-T trial, in which around 1,600 patients are randomized to the active treatment group, and the active monitoring were followed up for 6 years duration. During this follow-up, the sexual function was assessed, including the erectile function as well. So this preserved erectile function was seen in this 52% of this active monitoring group, 22% in this radiotherapy group, and 12% in this radical prostatectomy group, indicating that pelvic surgery has a significant effect on this erectile dysfunction. Then any patient or any man who undergoes this radical prostatectomy, any tectomy, irrespective of the technique, they should be thoroughly informed about the operation before the procedure and the significant risk of sexual changes other than erectile dysfunction, because they can have decreased libido, the changes in orgasm pattern, and ejaculation, and Peyronie's-like disease. Even there can be changes in the penile length. So we should tell the patient practically before embark on the surgical treatment. And in the research-wise, they have shown that 25 to 75% of men experience post-radical prostatectomy erectile dysfunction. And the patient age, baseline erectile function should be assessed before the surgery, and the surgical volume. And the consequence and the preservation of the neurovascular bundle have to have a relation. And there's a main factor depend on the surgeon. The surgeon who has more experience will have a more preservation of the erectile function. Also, even though it's mainly related to surgery, there's some relation even after this external beam radiotherapy as well, and the brachytherapy of prostate cancer. There was systemic review and meta-analysis, including patient treated with external beam radiotherapy. The 65% has this erectile dysfunction, and brachytherapy. The post-treatment erectile dysfunction at 1 year was around 34%. And there were this new focal treatment like this high flow cryotherapy, and this vascular targeted photodynamic therapy, and this cyberknife-like newer technique. All these newer techniques, they have reported to have less negative impact on erectile function, but the available data and randomized control trial data is still not strong enough for the come to conclusion. And mainly lifestyle modification with regular exercise and decrease in BMI, we can aim for improvement in erectile function. And we should keep in mind that erectile dysfunction is only a symptom, it's not a disease itself. When we come to the diagnostic evaluation, we should go through a medical and thorough sexual history about previous and current sexual relationship of the patient, and especially the patient emotional status and psychological aspect of the patient as well. And the onset of duration of this erectile problem and previous treatment or previous consultation. We should focus on the rigidity and duration of this both sexually stimulated rigidity and as well as the morning erection, which gives an idea about this physiological condition of the penis, and the assessment of patient's sexual desire, arousal, and orgasm. For this purpose, we should go for this validated psychometric questionnaires. One is this IIEA, which is this International Index of Erectile Function, where we are assessing the patient erectile function, orgasms, desire, as well as patient's overall satisfaction. And there are some questionnaires like this sexual health inventory for men. So these questionnaires can be validated and get idea about the patient sexual function at the moment. And for this erectile hardness, there's a score known as erectile hardness score for the assessment of penile rigidity. So always we should exclude any mechanical causes or treatable causes. So always look for, as previously mentioned by previous speaker, possible hypergonadism, and assess for this decreased libido and fatigue and potential cognitive impairment, and can be observed in association with hypergonadism. And always we should exclude the possibility of plaques in this patient. When it comes to physical examination, sometimes they may reveal unsuspected diagnosis if you are keen enough, like Peyronie's disease, and sometimes it can be a presentation of malignant lesion as well. The prostatic enlargement, irregular nodular lesion, and we have to be cautious of the, as previously mentioned, the features of hypergonadism. Then we should pay our attention to the penile abnormalities such as hypospadiasis, epispadiasis, any congenital curvatures, and Peyronie's disease with preserved rigidity. And we should calculate the BMI of the patient or waist circumference as a baseline. And proper cardiovascular and neural nervous system examination should be done. And because this cardiovascular system is always go in hand with this erectile dysfunction. When it comes to laboratory testing, as a baseline, we can go for a fasting blood sugar level or HbA1c to assess this glycemic function and lipid profile. And early morning testosterone level, as we mentioned in previous lecture, to 7am to 11am, can be done in patient with hypergonadism. The additional laboratory testing should be considered in selected patient to decide on this prolactin level and LH level. Important decision making is the patient's cardiac risk stratification, because the erectile dysfunction significantly increase the risk of cardiovascular disease, coronary heart disease, as well as stroke. So there was this Princeton Consensus Conference, which is dedicated in optimizing sexual health as well as preserving the cardiovascular health. According to that, they have categorized patients into 3 risk categories. These are mild, moderate, and high risk. For this mild risk categories, low risk category, they can start treatment for erectile dysfunction. So for the patient who are go under low risk category, they should have more than 6 MET level of performance stage. This MET is the metabolic equivalent. It measures the normal human oxygen consumption of a 70 kilogram man of 40 years at the rest, which is around 3.5 milliliter per kilogram per minute. So they depend on the physical activity, they can give the MET score. And when it's come to intermediate risk, they need to go this stress test examination, because this 4-minute treadmill protocol is equal to having a sexual activity. So if the patient cannot go through this 4-minute stress test, it means they have failed the stress test level. So they should be categorized as high risk patient.
Miranga, you have 4 minutes.
If they can go ahead with this stress test, we can start on erectile dysfunction treatment. All these high risk patients, they need cardiology management, and until that, they should stop their sexual activity. When it comes to this advanced workup for erectile dysfunction, we have this nocturnal penile tumescence and rigidity test, where we can monitor the patient's erectile episode, circumference changed by strain gauges, and maximal penile rigidity, and duration of nocturnal erections as well. There are intracavernous injection tests, where we can assess the rigidity, appear within 10 minutes of injection and last in more than 30 minutes. And for the arterial assessment of the penis, we have this dynamic duplex ultrasound scan, arteriography, or infusion of cavernosometry or cavernosography techniques. These are the advanced workup, and we should assess on the psychosocial workup as well, because this depression and anxiety-related disorders and relationship factors can affect the patient's erectile function. And the cognitive factors including male dysfunctional thinking styles and the expectation of the patient as well as the partner should be addressed. And for this, we have to use measurement scales like this sexual mode questionnaires to validate the patient's psychosocial status. When we consider the treatment option, we should consider the patient as well as partner education for the expectation. And we should identify the treatable and curable causes of erectile dysfunction, including lifestyle modification and risk modification. And there are intracavernous injection, vacuum devices, and oral pharmacotherapy as well. The main aspect of oral pharmacotherapy, because this phosphodiesterase 5 catalyzes this hydrolysis of second messenger cyclic GMP, which will go to this smooth muscle, the second messenger pathway, which incorporate this nitric oxide release. Which is associated with increased arterial blood flow and smooth muscle relaxation as well. So for the action of this NO2 release, there should be this parasympathetic nerve ending in the erectile penis. And for the NO2 release, there should be a sexual stimulation as well. So this patient who have this diabetic neuropathy will get lower effect because of this neurological involvement. And even after radical prostatectomy, if the nerves are damaged, the outcome will be low. When we are considering drugs briefly, the sildenafil was the first drug we have used, and it was effective in 36 minutes after administration, but its efficacy reduced with the heavy fatty meal due to delayed absorption. This tadalafil was considered to be peak efficacy after 2 hours of duration. It has a long-lasting acting up to 36 hours. The tadalafil was research-wise proven to increase this patient's this erectile function scores previously mentioned. This SEP score is the sexual encounter profile score, and this GAC score is this get active questionnaire, which all assessing the erectile function. Then there were new drugs like this vardenafil and avanafil. When we using these drugs, we should be cautious about the side effect and safety of the patient. They can get common side effect like this headache, this nasal congestion with parasympathetic activity, and mainly this cardiovascular safety. Up to now, the randomized control trial has not seen any increasement in myocardial infarction in this patient, even though there's a common belief like that. And there are some absolute contraindication for this drug usage. One is if the patient is using any form of organic nitrate like GTN, isobutadienitrate, and patients who are using NO donors. Some patients, they are using this as purpose for this recreational activity because it can increase cyclic GMP level, and it can cause unpredictable fall in the blood pressure level. And concurrent usage of nicorandil also is a contraindication for use of these drugs in the patient with erectile dysfunction. We can use them safely with this antihypertensive agent, but they might cause a small additive effect in the blood pressure drop. And all these drugs are metabolized in the cytochrome 3,3,4A pathway. So those drugs affecting this drug will affect the serum concentration as well. Then other treatment options are this topical or intravitreal alprostadil, which is a local vasodilator. So there are 2 delivery methods. We can use it as a cream that includes the permeation enhancer to facilitate absorption. Second method is this intravitreal insertion of this specific formulation. There are adverse effects like local pain, dizziness, and the rare dreadful complication like penile fibrosis and priapism, which are less than 1%. And we should use this psychosocial intervention and therapy depending on the patient's psychological level. And depending on the patient diagnosis, patient hypogonadism, we can start on this hormonal treatment, thinking of the primary testicular failure, secondary or hypothalamic causes. Then vacuum erection devices also depend on the patient preference, can be used as a first line or second line therapy because there are evidence to say they are effective treatment. This provide passive engorgement of corpus cavernosum together with the constrictor ring at the base of penis. Then there are intracavernous injection, which has to be a success rate around 85%. There are multiple commercial preparation like this alprostadil, and there are combination therapy. The alprostadil can be used as a monotherapy as well. When there are combination, it can be combined with papaverine, and there are commercial preparation like bimix and trimix. In bimix, they combine papaverine plus pentolamine, and in trimix, they are combine this with the alprostadil. So the emerging drugs are the drugs containing vasoactive intestinal peptide, VIP containing drugs. These are the intracavernous injection therapies. And this newer one are the regeneration therapy, like shockwave therapy and platelet-rich plasma and botulinum toxin. These are still at the research level, and there are some promising results. And depend on the further randomized control trial outcome, we can add them to our routine follow-up. And the main aspect is the surgical management. Surgical management can come under surgery for any patient who is having post-traumatic cardiogenic erectile dysfunction. In young patients who are having this pelvic or perineal trauma, surgical penile revascularization has a very good success rate. So it should be done. And is a success rate of 60 to 70% with long-term success rate. Then the other one is the penile prosthesis. This should be considered in a very motivated patient in Sri Lankan setting and are not suitable for different pharmacotherapies. Patients who are not suitable for different therapies and prefer definitive therapy, and patients who are not responding to other treatment modalities. The two currently available classes of penile implants include this inflatable and symmetric devices, which we were taught on this workshop at Anuradhapura. And there are two main surgical approaches. We can do penile prosthesis implantation, this penile scrotal incision, and there are two main complications, which can be the mechanical failure or infection. Thank you, sir.
Thank you very much, Niranga. Ajit sir, shall we have some discussion or comment on this?
Yes. I think even in our wards, we use at least papaverine, and you all must have come across this. So how do you counsel a patient before and after injection of papaverine, and what are the instructions that you give them on how to inject themselves, what to do, what not to do, and the aftercare, etc., and how to manage the follow-up care?
This should be done under sterile condition, and patient should be trained and educated well before the procedure. The patient can success rate depend on the technique, and patient should be educated about the rare side effect like this priapism and penile fibrosis, and patient should be educated about the time taken to the action to occur, and the time it might persist after injection.
You mentioned it's a sterile procedure. Is it a sterile procedure? Do you need, I mean, the patient is just going to have sex just before that in the toilet or something, he will do this? Intermittent catheterization, what kind of, I mean, the same kind of thing, isn't it? I mean, there is a little bit of alcohol swipe or something, stop or something. How do you instruct the patient to do the procedure, do the injections? Or how do you, for example, you are called as to conduct an MRI with alprostadil injection? How do you inject the alprostadil?
That was, I'm not sure, sir.
Okay. Anybody else? I mean, it's just to do with anatomy, isn't it? What do you need to avoid in the penis? And where do you need to inject it? What are you trying to, where are you trying to inject it? Anybody who knows can answer that.
should be 15 minutes before intercourse, and it should be at 3 o'clock and 9 o'clock, and it should not be vertical. And we should advise the patient if there's any bleeding, he has to press on that.
Yeah. So why did you say I agree 100% 3 and 9 o'clock? Why are you avoiding the 6 and 12 o'clock?
To avoid injury to urethra. Sir.
Yeah. So ventrally you have the urethra and dorsally you have the
neovascular bundle.
Yeah, neurovascular bundle is there. So you avoid those two sides and inject on either side. And actually, do you wait until there is bleeding to press on it, or do you routinely tell them once the needle comes out, you keep a gauze swab or something and press on it for at least 5 minutes so that there is no hematoma formation, which will take away all the fun for him with his planned activities, isn't it? So what kind of dosages are you used to with at least papaverine? Has anybody used the papaverine on your patients? So very simply, you have the common usage vial has 60 milligrams of papaverine, and ideally you should start off with the least possible, maybe 10 or at least 15 milligrams. So at least half a ml injection for the patient, and then if that doesn't work over several times, then maybe increase it to 30 milligrams, etc. Right? And as you correctly said, you got to warn him about priapism, and if it lasts beyond an hour, immediately come back to the unit. What are the measures? Sorry, we are doing a session on priapism, so I will leave that for that session.
Sir, can I ask one thing?
Yeah.
Hello, this is Sohan here. Niranjan, just to ask, what about the psychogenic rectal dysfunction? You keep an age limit for that? That is a bit common now. So in practice, like when you try to rule out this is psychogenic rather than any other cause.
We have excluded the other anatomical and correctable causes. And when we are taking this questionnaire about the patient psychological aspect of the sexual function, there's a hint towards the psychological aspect causes.
Usually in practice, we usually take as 40, like less than 40 now. People even at the age of 18 now come and say we have erectile dysfunction. So will Ajit sir agree with that?
Yeah, so definitely the young age groups, yes.
Okay.
Of course, I think, Sohan, we know that any man with primarily organic disease will also secondarily have some psychogenic component also, so that also needs to be addressed.
Yeah. Okay.
Niranga, I have a question. That patient is on PDE5 inhibitors, for example, sildenafil. He has an acute cardiac event. He has to use nitrites now.
Yes.
So how would be the time gap for PDE5 inhibitors and nitrite usage?
The T-half of this PDE5 inhibitors depend on the generation, sir. For this, it can last up to 36 hours in the T-half. So we should step it because both can have additive effects.
What they tell is for tadalafil, if he's on tadalafil 48 hours, if he's on sildenafil, it should be at least 24 hours. And if the patient is on tamsulosin as well, so what would you advise the patient taking sildenafil or PDE5 inhibitors and tamsulosin?
Both of them can have an additive effect and the pressure drop. So they should take them in 2 different time frames.
Exactly. So at least there should be 4-hour gap. So easy way is to take the tamsulosin in the morning and PDE5 inhibitors in the night. And one more question, what is the main difference between this local alprostadil and PDE5 inhibitors?
This local estradiol is a local vasodilator, sir.
The mechanism of action, is there any difference?
That it does not depend on the this NO release from the nerve endings.
Okay, so alprostadil does not need this NO, so does not need any sexual stimulation or partner's help. For patients like that, you will prefer that kind of medication rather than PDE5 inhibitors. Okay.
Shall
Yeah.
we move on to the next?
Yeah, Nishant.
Next topic is ejaculatory dysfunction. Will be done by Dhanendra Madhushankar.
Hello, sir.
Yes,
Hello,
we
sir.
can hear you.
Can you hear me?
Yeah.
Can you see the slides? Hello. Can you see the slides as well, sir?
No, not yet. Yeah, we can see the slide view now.
So is it visible now?
No. Blank.
Just give me a minute, sir.
Okay.
So is it visible now?
Yeah, we can see now.
Okay. Thank you very much. Today I'm going to discuss about ejaculatory dysfunction. Before moving into topic, just physiology of ejaculation. It consists of three main steps, which is emission, ejection, and the orgasm. And this ejaculation is consists of multiple neural pathways, which involve sensory and motor cortex system, spinal cord level, and the afferent and efferents from genital regions. And same time, it involves multiple neurotransmitters like adrenergic and cholinergic, as well as serotonergic and dopaminergic pathways. And out of these mechanisms, it causes this emission, ejection, and this orgasm. And the emission were the contractions of the associated accessory sexual organs causing release of sperms, and then same time in ejection phase the bladder neck closure and causing again bulbocavernous and bulbous spongious muscle, which will cause the sperm ejection, and followed by its cerebral processing, which is due to this pudendal nerve stimulation. The person will feel orgasmic sensation, and any problem of these pathways can lead into ejaculatory dysfunction. So again, it's a spectrum of dysfunction. It can be too early or too delayed, and the dysfunctions can be premature ejaculation or delayed ejaculation, anejaculation, retrograde or painful ejaculation, and a current concept of post-orgasmic illness syndrome. I am discuss more about premature ejaculation here. It is kind of misdiagnosed and mistreated entity where it is characterized by very short ejaculatory latency. This ejaculatory latency defines as the start of the penile stimulation until the ejection is occurred. So how to define ejaculatory dysfunction? Campbell also tries several ways of definitions, but there is no such exact definition. So out of them, which is persistent or recurrent ejaculation with minimal sexual stimulation, which is before or no slightly after penetration, and without patient's control over it, which result in psychological and sexual impairment. And then later it further defined by this International Society of Sexual Medicine. They divide this premature ejaculation or PE into 4 main groups, and they define ejaculation that always or nearly always occur prior to within 1 minute time of vaginal penetration, which is known as lifelong PE. And then if it is clinically significant or bothersome reduction in latent life, it defines less than 3 minutes, which is acquired PE. Then it will result in this inability of delay ejaculation in all or nearly all vaginal penetrations, which lead to negative personal consequences like this distress, bothersome, or sexual failure. And the other two types are the variable premature ejaculation and the subjective PE. Variable one is it inconsistent or irregular early ejaculations, and it represents normal variations in sexual performance. And subjective PE is a kind of normal variant, not a true premature ejaculation, where the latency period is within normal range, but subjective perception is there of premature ejaculation. So depending on these 4 types, the epidemiology wise, there's prevalence is less than 10% various types, and earlier their prevalence quite of like 30% because of there's no clear-cut definition. And why the people develop premature ejaculation, the etiology and pathophysiology is not well understood. But there are strong association with erectile dysfunction, and most of the times it is misdiagnosed with erectile dysfunction patients as well. And some associations within this age group, race group, black men, Hispanic men, and Islamic people have higher tendency, and some poor social group, poor economical level patients, and some prostate related pathologies or hormone and endocrine problems, they are having a strong association with premature ejaculation. And this impact on quality of life is mainly it affects the sexual life, so thereby failure of sexual life as well as lead to anxiety, depression, and most of these patients do not seek documentation. When come to patient, how to diagnose premature ejaculation, it's based on basically a good medical and sexual history, and there we concentrate on 4 aspects mainly. One thing is the time to ejaculation, which is assessed by this intravaginal ejaculatory latency time. It is measured either self-estimated or Stopford measure in research basis, and then perceived control and the distress level and the interpersonal difficulty. So this intravaginal ejaculatory latency time is basically directly related to perceived control of ejaculation, and thereby it also indirectly associated with ejaculation related personal distress and the satisfaction of sexual intercourse. To get the idea more of these symptoms, we can combine these symptoms into a questionnaire, which is single item patient reported outcome or pro questionnaire, and thereby we can scale out the quantity of the symptoms. Then how to diagnose this premature ejaculation? Again, there are certain questionnaires which are laid up. Premature ejaculatory diagnostic tool, which is a well-validated, currently practiced one, and the Arabic index of premature ejaculation. So by these questionnaires, we can diagnose and quantify the patients. Once we diagnose the condition, then how to treat these patients? It is basically starting with a patient, both partners and the patient counseling, and psychosocial education should be there, and we have to exclude the erectile dysfunction and other prostate related current conditions which lead to premature ejaculation. And then treatments, basically there are 2 arms, which is pharmacotherapy or else behavioral therapy. And behavioral therapy, they are mainly include this stop start technique or squeeze technique, sensate focus techniques are there. But pharmacotherapy plays a main role, which is kind of first line therapy. And what are the drugs we can use dapagliflozin, which is SSRI, which is short-acting, safe, which has rapid action, and we can advise the patient to take it before 1 to 2 hours before the intercourse, and dose is about 30 to 60 milligram, and it has less side effect profile and as well as less interaction with the other drugs. So thereby it will increase the serotonergic pathways, thereby delay the ejaculation time. And it is the kind of first line drug. And there are some off-label drugs which are SSRIs and tricyclic antidepressants. And their problems are they can cause this tachyphylaxis, and sudden cessation or rapid dose reduction can lead into withdrawal symptoms. And there is a theoretical risk of suicidal attempts in these adolescents can be there. So be cautious about them. And other agents we can use are topical agents, lidocaine or pilocaine preparations, which can be used before the intercourse. It will reduce the gland sensation and thereby increase the ejaculated time. And tramadol also plays a role by centrally acting and reducing the ejaculation time. So we can use those methods to treat premature ejaculation. Then comes to delayed ejaculation or anejaculation. It is a group of symptoms which is characterized by either physiological or psychological or medical disease or surgical procedures that interfere the previously mentioned the central pathways of ejaculation mechanisms. Thereby, ultimately it results in either delayed or anejaculation or retrograde ejaculation. So causes, there is a huge list you can go through in the Campbell. They can be either psychogenic causes, and then congenital anomalies can be there, and anatomical causes, and especially prostate-related surgeries, interventions can lead into this delayed or retrograde ejaculation. And neurogenic causes, especially diabetes, plays a main role, and other peripheral nerve-related problems. And infective related to urethra, prostate, seminal vesicles can lead into these problems, and endocrine thyroid diseases and hypogonadism, as previously mentioned, plays a main role, and some medications. And earlier we used serotoninergic drugs, they can cause this problem. And how to evaluate this kind of patients with delayed ejaculation? Again, we have to go through a thorough history and examination, and we have to assess their hormone level and additional investigations depending on the previous findings. And there are certain questionnaires they have prepared to go through in these patients. In the treatment, we have to first identify the cause, and it should be cause-directed treatment. And basically, these patients need, like early patients, psychoeducation and psychosexual therapy. And then if failing, we have to go for drug treatment. This is a kind of flow chart we can use to address these kind of patients. Once we get the patient of delayed or anejaculation, we have to first go through whether the patient is having orgasm. If he is having orgasm, but if there's no ejaculation, then we need to rule out retrograde ejaculation. How to rule out that? By we can check post-orgasmic urine sample to see the presence of sperm. And if the sperm is retrograde ejaculation, then the management differs along that pathway. And if the patient doesn't have any sperm production, so then we have to manage as azoospermic patient. And if the orgasm is no, or if there's reduction, then we have to evaluate on that aspect, and mainly psychosocial therapies, those things play a main role. And in delayed ejaculation, what are the treatments of pharmacological treatments? There are drug treatments plays kind of limited role, but still drug treatments are there by mainly by facilitating central dopaminergic pathways. The drugs we use are cabergoline, amantadine, pseudoephedrine, and oxytocin, like agents we can use. And a bit about retrograde ejaculation. In usual anterograde ejaculation, there should be bladder neck closure as well as contraction of the posterior urethra and relaxation of the other parts to facilitate seminal ejaculation. But here, it causes reversal, whereby the semen goes to bladder and patient feels he doesn't have any ejaculation. So we can confirm it by checking post-ejaculation urine specimen, and their presence of 5 to 10 sperm per high power field confirms the retrograde ejaculation. Usually these things associate with urethral-related interventions mainly. So treatments mainly, surgical treatments have less results, basically blood and neck reconstructions, but drug treatments plays main role. They are also treated by basically pseudoephedrine, ephedrine treated drugs, and this TCS and SSRI also plays a main role. And if both treatments are failing, we have to go for sperm retrieval methods, either from urine sample and by centrifuging and isolating of them, or testicular sperm retrieval. Then bit about other conditions. Painful ejaculation, it's also poorly characterized condition. It can associate with these kind of infective processes like urethritis or BPH, prostatitis, seminal vasculitis, and other calcular disease. So they also have a kind of association with LUTS and BPH patients as well, and who are using these alpha blockers. So those patients we can treat with like selective alpha blockers, like alpha-zocine. Alpha-zocine is kind of a drug which produces these kind of symptoms. And this post-orgasmic pain syndrome is kind of a novel concept where following ejaculation, patients feel kind of severe symptoms of myalgia, fatiguability, flu-like episodes, and it kind of starts from within 30 minutes and lasts for about 1 to 2 days. And this is poorly understood. The hypothesis is mainly due to this type 1 hypersensitivity reaction, and it is kind of treated with treatment methods are still they are in research level. NSAIDs usage before ejaculation is one method, and other thing is they try with subcutaneous injection of autologous semen to prevent this hypersensitivity reaction also plays a role. And that conclude my presentation on ejaculated dysfunctions. Thank you.
Thank you, Dr. Nirendra. Ajit sir, Dr. Sahan, any questions or comments?
Dinendra, congrats, nice presentation. Now you mentioned this lifetime and acquired premature ejaculation. In those particular types, as far as management is concerned, is there a difference in the emphasis of treatment that you use?
Yes, sir. In this lifetime premature ejaculation, sir, the main treatment is on drug treatments, and then they are all in every intercourse they are having this premature ejaculation symptoms. But this acquired scenario, there is not always. Some instances patient feel premature ejaculation. So there we can, along with drug treatment, psychosocial therapy and other behavioral modifications can play a main role, sir.
Narendra, can I ask two things? One thing is,
Yes.
like premature ejaculation, what is the time you save to the patient? Like this much? Is it 10 minutes, 5 minutes, 15 minutes? That's one thing. Second thing is depoxetine. What is the commonest side effect they come and complain?
For the first question, sir, the time is, it should be more than 1 minute, not less than 1 minute. And it is not a strict time guideline. The patient feel should be the main concern, patient satisfaction and the partner satisfaction. But at least it should be more than 1 minute, sir. And when using depoxetine, it's kind of safe drug with side effects, but still they are having this nausea, fatiguability, and some GI related problems they can feel. Sir.
Usually what they come and say is headaches. Yeah, that's the commonest thing they will, this practical things, they come and say headache. Okay.
Yes. Yes.
Ajit sir, how would you manage a patient with retrograde ejaculation in our setup, sir? What are the drugs available?
To be honest, very minimal. Pseudoephedrine is sort of an available drug in other countries, and even for autism patients, sometimes they use that. Now, some of these cough syrups do have these sympathomimetics embedded in them. So some of them can be used to benefit these patients. But apart from that, to my knowledge, there is very minimal that can be done. Sometimes, even in the sort of the anecdotal evidence literature, there is a mention of this imipramine being used 25 milligrams BD over 7 days, and get these people who have supposed retrograde ejaculation to ejaculate and see, and sometimes they do void. Now, that is not in the guidelines or anything, but practically sometimes that does work. I think retrograde ejaculation is a very difficult situation to treat without proper sympathomimetics being available. Sohan, any opinions?
No. No,
Could I ask-
actually, I
could I ask
also have not
something?
come across anything. to be
Hello?
frank.
Could I ask something?
Yep.
This depoxity, what is the timing of taking the depoxity? I joined you all late, so I might have missed that. Is there timing of taking depoxity? That is premature ejaculation. How early should you take it before the sexual act?
So they say 1 to 2 hours prior to the intercourse. That
Yeah,
should be
now they
taken.
say 3 hours. 3 hours before. Ijalagan, all these, and then tramadol some people use.
Yes.
What they say is about 3 hours. So some people actually won't allow this to act, you know, so they take it about 1 hour before. Sildenafil about 1 hour, and that is for erections, and this is about 3 hours. So sometimes, you know, when you change that timing, it has worked. Just a comment.
These recent the guidelines also mentioned about apart from local application of pilocaine and lidocaine, the sprays are available, and I think they are in the guidelines as well as I think it's FDA approved. So I think that may be something that because it's a very short acting, I think within 15 minutes or so the patient can immediately spray it, even 5 minutes before the sexual act. So I think that might be very patients may be very happy to do that rather than trying to time it for 3 hours before, etc. So
Yeah, great.
Okay, we'll move on to the last presentation for the day. It's going to be done by Dr. Muhammad Nabil on Peyronie's disease and vasectomy.
Hello, can you hear me now? Hello, can you hear me?
Yes, Nabil, we can hear you. We can't see your screen. Yeah.
I have shared my screen. Can you see my slide?
Yeah, we can see a first slide.
Yeah, okay.
Slide, yeah.
Okay. Good evening, everybody. My topic is today about the Peyronie's disease and vasectomy. So I will consider about the Peyronie's disease condition, right? And regarding Peyronie's disease, this condition commonly seen in urological practice, but in our practice, we usually not see much patient because probably still poorly identified and understood in the wider medical community, and certainly by the most of the public, because to identify the concerning appropriately referring affected patients can significantly reduce the physical and psychological effect. Usually, patients are not much coming with this kind of conditions when they are because they are shy to show, and sometimes there's a more problem with psychosocial issues. And in relevant to the epidemiology, so 1 in 100 men in the United States over age of 18 have the diagnosis of Peyronie's disease. However, based on studies of men who reported having the symptoms of Peyronie's disease, researchers estimate that actual number of women who have erroneous diseases more than 1 in 10. So that is one
Nabil,
of
there is, sorry to disturb you. There is some background noise. We can't hear you clearly.
Now, here now, sir. Wait. Is there background noise now, sir? Hello?
Should be okay, I hope. We'll continue. Yeah, please.
Can you hear me now clearly?
Yeah, yes, Nabil. Yeah.
Right. Okay. When related to the pathology, the peronis is a fibromuscular disorder, the tunica albuginea of the penis of corpus cavernosus. So the most commonly accepted hypothesis for the development peroneus disease is that genetically predisposed men with repetitive microvascular trauma to the tunica albuginea associated with the penile buckling in the erect or semi-erect state secondary to sexual activity or other even sports activity events initiate the cascade of extravascular protein deposition and fibrin trapping and macrophage secretment and cytokine overexpression and release of elastin. This leads to change in the tunical collagen from predominant type 1 to type 3. These structural changes on tunica subsequently leading to development of the fibrotic plaque. So this some possible etiology are most usually vigorous sexual activity and non-sexual activities like sports, heavy contact sports, and with long-term micro injuries to the penis, and having a connective tissue disorders and autoimmune disorders also in the underlying theory, and have family history of erroneous disease also considered. Then aging when considered, the more older people are getting associated. The diabetic and erectile dysfunction people are more associated with this erroneous disease and have history of prostate cancer with the treatment like surgery, pelvic surgery associated more related. So these are the conditions where associated ones, liputin contraction and some connective disorders I have mentioned, like SLE and scleroderma and Sjogren's syndromes. And when compared with the clinical presentation, usually this is mainly diagnosed with a history and examination where the physical examination of the penis, where they have coming with a history mainly pain and there is a nodule or plaque formation and coming with a curvature. The most common presentation is the penile curvature, curved penis. It's the commonest one. Second most commonest one is the pain in the penis while on erection or without erection. Because other things are plaque or nodule, they can feel the plaque or nodule. And some people coming with the penile shortening due to this issue, and the other one associated with erectile dysfunction, mainly ranging from 22 to 54% of erectile dysfunctions are associated. So when we come about the natural history of the disease, there are two phases, mainly active phase and the stable phase. When we consider about the active phase, it is characterized by dynamic and changing of symptoms associated with the penile and glandular pain, mainly discomfort with or without erection. That is mainly the active phase, we have pain. In stable phase, where the symptoms are clinically silent for at least 3 months and deformity is no longer progressive. So almost what are the achievable, almost achieved. And the curve and everything, so may in a stable phase that can progress in the later, or it may be progressing the repeated active phase. So when we come into the study, examining the natural history of peroneus disease, usually some who have had the active phase without intervention, they can 12% of the people can go in the remission without any treatment and some remain stable in the 40%, some worsens in the 48% over 12 months. That was the study, the examining of the peroneus disease patient. When it comes to the management, usually I didn't touch about more about the ultrasonic diagnosis and the imaging modalities. They are not much applicable rather than except ultrasound and the duplex scan of the ultrasound, where we have done the anatomy of the arterial and the venous phases to look at the anatomy, any vascular insufficiency mainly exclude, and the thing they don't have much role in the measurement of the size of the lesion as well, size of the nodule as well. So the erect penis MRI is other modality, but they are also in a less practice as well as not very useful to give a more details about the disease. But whenever the surgery, before surgery, we can consider those. Whenever we needed a stable disease to the surgery. So when we come about the management, the surgical therapy has been traditionally considered the mainstay of treatment in the stable phase of the peroneal disease. So pharmacotherapy has been investigated to potentially improve the function and the deformity as well as stabilize the scar progression in patients with active phase of the disease. Usually the pharmacological management is mainly targeted on the active phase of the disease, mainly pain management and the scar progression management and the deformity and management. So when we come out the non-surgical treatment, so one of the treatment it includes injection, intralesional injection, and oral medicines and the medical therapies. There are therapies. They may be used when peroneal disease in the acute phase. So injections are mainly injected into the plaque. Those are called intralesional injections. Can be used in the common. I will come into that main detail about the collagenase, Clostridium collagenase exploiticum injection. That is the only one which is the FDA approved one for the to prevent the progression of the disease and plaque regression as well as curvature reduction as well as the short erection, reduce the size of the plaque and everything correlated with the collagen study. I will come into that. So those who cannot be given a collagenase, we can give the verapamil or interferon alpha 2B injections to the intralesion. Those are intralesional injections which are given in the acute phase of the disease, the stable phase of the disease of the plaque, where the plaques are have stabilized plaque with shortening of curvature P. We can reduce the this plaque size as well as curvature with the intralesional injection. So when we come to the pharmacotherapy, main target of this pharmacotherapy, because surgical therapy has been even though traditionally considered this stable disease, pharmacotherapy is under investigation. So to potential to improve the function and reduce the deformity and stabilize the scar. However, none of the oral agents, whatever used in current practice, have considered demonstrated benefit in the correction of penile curvature or decrease in the plaque size. But non-medical therapy, there are therapies which are using the mechanical traction therapies and vacuum devices aimed at stretching and building the penis to reduce the curve. Those also not have, even though used with a, even combination with some studies, so some collagenases, even that is not suboptimal. But in the alone, the traction therapies in the lesser curvatures, maybe less than 30, have some beneficial, but otherwise the traction therapies and vacuum devices are not much giving importance. But shockwave therapy, usually, even though in studies they have focused for only the pain reduction, but there is no evidence showing the shockwave therapy for the plaque reduction, no any curvature progression reduction. So the rationale is here mainly the peroneal disease is the for ESWL to reduce the pain, the pain of the plaque and the penis, while erection no, without erection. So some studies which was used to build the collagenase, the usage studies which was conducted from 91. There are steps which was done from the 1985 in the phase 1 study. We have given 31 patients the peroneal disease who received the intralesional injection for Clostridium collagenase histolyticum injections for 3 days. With the 4 weeks postpartum treatment assessment, they have come across 65% which had a complete resolution of the penile plaque, and 50% to reduction in the penile curvature, and 93 of those with the pre-treatment penile pain at pain resolution. So there's some complications of inject site bruising and some one case suggestive of the coital punicle rupture. So with that, progressive studies have validating that study in 1993, and after that there is a phase 2 trial where they have subsequently that also resulted with some modifications with the penile modeling. They have taken into the penile modeling with the intralesional injection. That's also have showing some continued demonstrated objective and subjective benefits of Clostridium collagenase historicum injection offer additional benefit. And this IMPRESS trial, where it has shown that it also in the trial, which is the phase 3 trial, which has shown the same effectiveness with all the studies included in the 417 and 459, which was done in the UK as well as in Australia, which was the 0.3, 0.58 Clostridium collagenase injection, and in the site separated by 24 to 48 hours, 72 hours, followed by penile modeling with the 4 treatment cycles they have in the regimes with rest period of 6 weeks. They also demonstrated the reduction of the penile curvature is significant at the end of the 52 weeks. They were after a 1 year study, 1 year the outcome, the treatment group demonstrated significant improvement in the penile curvature as well as the mean change in the symptoms bodily mind. It means the sexual function, their pain, and their satisfaction. The penile is a questionnaire, Peronis is a questionnaire, where while the psychological and physical symptoms was assessed. Then that also have a good positive results in this study to use the in a stable disease until if you not considered for the surgical method, intralesional injection would be a better option in this the selected group of people. And the main side effects of penile ecchymosis and swelling and pain, and somehow I have noticed about the tunical rupture, postcoital tunical rupture. There are therapies used in the trial. There are oral medicine which was used. There are potassium paramino benzoate is only mainly there's only reduce the plaque size, but they have no any other medicine which was used, vitamin E and colchicine. They have used the phosphodiesterase 5 inhibitors and pentoxifylline. There are anti-inflammatory, antifibrotic properties of drugs which were not anything not showing the effectiveness of this treatment for the Peyronie's disease. Or surgical treatment.
Nabil, to interrupt, you have 5 more minutes, please.
Yes, sir. To avoid the surgical management, mainly the indication where the surgical treatment, the stable disease, compared ability and inability to engage coitus, and extensive plaque calcification, the failed conservative treatment, and patient wants the most rapid and reliable result. So those are the main indications of the surgery. So surgical options are mainly grafting and application and the device implanting. So how to decide on the surgical algorithm is just a summary where when the rigidity is adequate, it means the erectile function is good. That when these criteria are fulfilled, it means the curvature is greater than 60 degrees, no disabling hourglass deformity, or predicted loss of length is less than 20% of the erect length. Then we can consider the application, tunica application. So otherwise, curvature is greater than 60 degrees and disabling hinge, significant curvature, then consider the plaque excision and grafting. So that is the two ancillary procedures which can consider for the Peyronie's disease and surgical action. When the erectile dysfunction is there, it is suboptimal and poor refractory to medical treatment, then consider the penile processes with or without the ancillary procedure. And if there are graft and outcomes of these things they have noted after procedures, mainly there are some studies showing erectile dysfunction is 0 in after the procedures, and the stapling around 100%, and they have followed it in a 2 to 3 years of follow in a different studies. And when you compare to the application procedures, those are grafting procedure, mainly the Nesbit and the tunica application procedures. They have some split procedures. In 2005, they have conducted the stapling around 100%, and with the absence of erectile dysfunction in they have not much follow-up, but in outcome in the too early phase, they have noted zero erectile dysfunction. That kind of the public data is suggestive of this procedure. And they have used the different types of graft for the excision of a graft. There are different autologous and non-autologous grafts. I just mentioned, I don't want to mention, just go through. And this is the mainly treatment of algorithm from the EU guideline, but I have already mentioned, the summary I have mentioned here. That's all my key points regarding the proper diagnosis and evaluation of the history taking and physical examination and objective assessment of the penile deformity is mandatory prior to treatment, and oral therapy has not been generally shown to be beneficial in either acute or stable phase of the peroneal disease. Extracorporeal shockwave therapy may help to reduce the pain, but not the penile deformity. Intralesional injection therapy with verapamil or interferon 2 alpha may be offered to patients. Intralesional injection therapy with collagenous Clostridium histolyticum in combination with manual modeling may be offered to patients with stable Peyronie's disease, penile curvature of greater than 30 and less than 90, and intact erectile function. Intralesional injection therapy with collagenous Clostridium histolyticum is not indicated for patients with Peyronie's disease or curvature greater than more than 90 degrees and ventral curvature, hourglass deformity, and calcified plaque. And patients should be aware of potential adverse effects of intralesional collagenous injections. To date, there are no head-to-head comparison between the intralesional injection therapy and surgery for Peyronie's disease. There is insufficient data to recommend the routine use of penile traction therapy concomitantly with intralesional injection therapy. Thank you. And regarding the vasectomy, I just go through some important about slides. The mainly safest and most effective type of permanent contraception is relied upon the 40 to 160 million men in worldwide. The consequence of adverse outcomes such as vasectomy failure have resulted in the highly litigious procedure in the United States. So 1 in 60,000 men have a trouble vas on one side, potential cause for vasectomy failure. 1 in 400 men have the absent vas on one side associated with absent kidney on the same side. Let's have a fact to remember. The main concern about the preoperative preparation about the vas.
Obtained through thorough medical history, and important points to address include mainly contraception immediately after vasectomy, and complication and failure rate. This should be discussed, and potential for fertility restoration with sperm banking and vasectomy reversal, and availability of the alternative method of contraception. And the mainly common misconception I have identified, because after vasectomy, the vessel fluid contributes only 2 to 3% of total semen fluid volume. So patients should be reassured that there will not be a noticeable change in semen volume and appearance. And time to sterility means it takes around to 1 ejaculation or 3 months post vasectomy. Otherwise, some sperms, and which is non-motile sperms as well as some motility sperms will be there in the conductive part, which can be present as for the fertility. So complications, where vasectomy has long history of safety and significant complications, which are rare, and large series of over 60,000 vasectomies reporting a significant complication rate of 0.9. Only common complications: local hematoma and wound infection, and chronic ocalgia and sperm granuloma. Among significant complications, there are two: the 4 years gangrene, 4 years gangrene, and 1. While the mortality rate associated with the vasectomy is 0.1 per 1 lakh procedures. And vasectomy failure is defined as inability to attain the negative post vasectomy semen analysis and occurrence of pregnancy. And early failure is the rate of early failure or inability to achieve azoospermia or rare non-motile sperms can occur in anywhere from 0.5 to 5.3 cases, depending on the vas occlusion technique used. However, in experienced hands, the early failure rate can drop to up to 0.2%. So reoperation is indicated in these cases. Late failure rate, once the post-vasectomy semen analysis confirms sterility, risk of late failure falls approximately 1 in 2,000. So there is no evidence that vasectomy increases the risk of testicular cancer or prostate cancer or heart disease. Surgical techniques, mainly the two key steps in vasectomy are isolation and occlusion of the vas. Isolation techniques include the conventional or incisional vasectomy or non-scalpel vasectomy. And non-scalpel vasectomy results in lower rates of bleeding and hematoma, pain and infection, as well as short operative time and quick return to sexual activity. So vasectomy is usually performed under local anesthetic. There is no difference in outcome between the cautery or ligation of the vas. Transient appearance of the sperm occurs 0.6% of the men even after negative sperm test. So risk of pregnancy about 1 in 3,000 remains, as a tube can rarely spontaneously rejoin. So the risk of long-term pain and pregnancy are important medical legal issues that must be clearly documented and communicated to any patient considering vasectomy. So key learning points: issues must be addressed during the preoperative counseling. No scalpel vasectomy technique has vas isolation and isolated with the lower complication rates. Contraceptive effectiveness of vasectomy is most clearly linked to the vas occlusion techniques, and technique chosen should be a failure rate less than 1%. Post vasectomy semen analysis showing either azoospermia or rare non-motile sperm is required to confirm sterility. Thank you. Hello.
Yeah, thank you, Nabil. Ajit sir, Nabil sir, Dr. Sohan.
Nabi, can I ask one thing? Now,
Yes,
when you are discussing about plication, the thing of shortening comes. So how do
yes.
you advise a patient about the angle and the shortening?
Yeah, when there is more than 60 degree, we usually 16 bit applications are undertaken usually less than 90 and more than 30 degrees. So shortening, we try to minimize less than 20%. It means for shortening is more than 20% comes, we have to consider some lengthening procedures like grafting has to be, we have to do the grafting technique rather than the application technique. So we have to counsel the patient according to the length, wide direction, what is the length, what is the expected length after the procedure, and it is possible.
Yeah, so no. So how do you tell now? If he will ask, okay, how many centimeters am I going to lose? What are you going to tell?
Yeah, how it lose means according to the curvature, it is if it is at 10 to 15 centimeter according to the length, you will lose around 20% of the length, around roughly.
Yeah, usually the guide, like what they say is every 30 degrees, 1 centimeter.
Yeah, up to 60.
Like in the UK, what they say is, okay, if you have to correct 30 degrees, you are going to lose 1 centimeter.
Can I ask something? Yeah, short question. Can you hear
Yes.
me? Yeah.
Yes, sir. Yes, sir, I can.
Now, what is your idea about plaque excision versus plaque incision?
Yeah, plaque incision. Incision means the plaque. We remove the plaque part with.
Actually, it's not removing the plaque. You incise it in several places and stretch it. When you excise, what is the problem? How would you counsel this patient for erectile dysfunction following plaque excision?
Because we are disturbing the tunica albuginea, where the erectile corporal tissues are disturbed, where they have the filling of these erectile tissues will be disturbed and it can cause the erectile dysfunction.
So will you warn the patient against this or regarding this? And if he asks, what are the chances that I will lose my erection after the plaque excision procedure?
There are chances, and even studies they have shown there are percentage of erectile dysfunctions, but with the procedures, the application procedures, usually some studies we can still even they can have even normal erection with not a pre. We can't expect the pre-erection, but there will be, less, but there will be some erection.
The practical point here is that before going for plaque excision, or straightening, make sure that the patient can't have any coitus. So you can always, when you are any intercourse. Because if you can't have intercourse,
Yes.
before and after, it's going to end up in the same place. The problem.
Yes.
So you will escape. You can say, so don't go for sort of minor curvatures, plaque excision, and things like that. Till there is failure in doing intercourse, don't go for that. So when practically it's not possible, then of course it's easy to counsel the patient. And plaque excision and what do you think gives the best outcome when you think of a graft?
Yes.
Yeah.
Better outcome means when we come out the plaque efficient, because erectile dysfunctions are more when compared to graft, when compared to the application. But grafting procedure will reduce the lengthening, shortening things.
Yeah. So okay, so the various material is available for sort of replacement of the defect. So my preference is for saphenous vein, the upper saphenous vein. Okay.
They have shown the saphenous vein is done. Study is the one which is more have a erectile dysfunction less. They have.
Yes.
In the,
it's much better. Okay.
Yes.
Thank you.
Thank you, sir.
Nabil, I have one question. You mentioned about this collagenase, the Zyflex. What do you think is the usage now, even in European countries? Is there some significant problem regarding it? Some restrictions in use? Have you heard of anything?
No, sir. Sorry, sir. I have not heard, sir.
Yeah, I mean, I don't think any of us have used it on our patients because it's about 20,000, 25,000, 30,000 US dollars for the entire course. But even in the European countries, it is now restricted use because they have identified that people, I mean, I think about 0.5% can have a penile fracture due to weakening of the corpora. And it is now currently used only in a sort of a risk evaluation and mitigation strategy, the Zyflex REMS program. So in Europe, ideally it can be used only under that program. So it's not available freely for people to use. So I think we are back to very conservative measures or surgical treatment in the patients, as Prof. Neville very correctly identified and told you, in the patients who cannot have penetrative sex. Thanks.
Yes, sir. Thank you, sir.
Aditya, what is your comment about the experience about shockwave therapy? How many cycles and how often?
Yeah, Peyronie's disease, of course, I mean, I don't use it because the evidence is lacking to correct the penile curvature. But definitely, I mean, in patients who have very mild to moderate erectile dysfunction, short duration of less than 6 months, and people who have maybe tried only medication and who are willing to try another modality to try and increase their sensitivity to the or results with the medication, or even try to get off it. Yes, that is a very useful treatment, and there is definitive evidence that it can work. And with the machines that are available and what I have used, I mean, there is quite a good response rate in these patients. Of course, one advantage is that it has zero side effects. Disadvantage is it is very costly. So private sector only availability. So in those who are properly counseled, properly selected for this procedure and who can afford it, I mean, it's a very good thing to try out. As far as the course that is given of shockwave, generally 6 setting sessions of shockwave is what is prescribed. maybe at least 48 hours in between 2 sessions, spread out over 2 or 3 weeks. That is generally the standard treatment that is understood to be effective.
Thank you. Any other questions? Nishanta, any questions?
No, Taha. No.
Ajit sir, there's a question saying that any other drugs used in Sri Lanka in the active phase? Have you come across anything? I have seen some people using vitamin E.
Yeah, I mean, if you look at all the trials, etc., all of them mention that none of these oral tablets have any benefit. Yeah, so I mean, I just tell my patients, you know, whether you take it or not, it may not give you benefit, but you know, at least some placebo effect if they are willing to try and if they understand that significance, you know, I mean, that's the only way I would use it. Otherwise, there is no evidence to benefit them.
Nabil, you said that after vasectomy, you will advise the patient to use other contraceptive methods for 3 months. What is the reason?
Yeah, main here is after even vasectomy, patient might have with the male might have the sperms which is in the conductive system that can come to the for the fertility. So with the patient with the post vasectomy, because only small length we are removing, this is around more than 25 centimeters the vas difference length. So where it can lodge the sperms and it can come to the fertility. So when after 20 ejaculations, they recommend to after 20 ejaculation only it can be cleared. Oh, it means otherwise it is we have to wait until the 3 months to clear out the this sperm from this duct system.
Why 3 months?
Huh?
Why 3 months?
Because
that is for Sri Lanka, the practical aspect.
I think it's something to do with the lifespan of the sperm, no? 72 days.
Yeah, 72 days, yes. So yeah, that's why the sperms are there in the system that can be lifelong in the system. So otherwise, the sperms which were in the testis or in epididymis, it is not going to come in the acute setup. So in the duct system, which is already there, it has lifespan around 3 months. Yeah, it can comes for the fertility in the concept. So I think that is why they are recommending 3 months abstinence, other usage of the female or male part contraceptives, and for otherwise 20 ejaculations, at least 20 ejaculations, which can have a propulsive effect of these systems, which can minimize the risk of fertility.
What are the procedures you will do in vasectomy to reduce the rate of failure?
Reduce the failure. Mainly, we have to one thing we can technique, which is the occlusion technique, which is the one we are using for the vasectomy, which can reduce, and other things we can reduce the segments, the rejoining and of the recanalizations, which can be preventable. We can remove the segments of the vas, which can reduce the future recanalization and the failure of the vasectomy. Except other than that, I don't have ideas.
If I may add, there is another technique of burying the ends in the fascia, internal somatic fascia. Yeah,
yes,
you can tie it, burn the ends, and then yes, there's intervening. You put internal somatic fascia intervening, so that also prevents recanalization.
Thank you, sir. Yes, I forgot. Yes.
Right. As sir said, it's like segment removal, facial interposition, and folding, cauterization.
The most effective one is the facial interposition they have shown in the studies. That's what I have gone through, sir.
There's a request for expert panel. If I mean the last speaker is not here, it's on andrological emergencies. So if there is any volunteers, we can do 2 cases. Ajit sir, what do you think? Maybe on priapism and penile fractures in all scenarios. If there are any volunteers, ladies, or any. Is there any volunteers from the trainee? Nishant, I think all have gone, I think.
Better
I
to
think-
stop it now, no?
Okay. Okay.
Still about 17 or 18. Is it
Yeah,
only us
if
remaining?
Nishant or somebody, one of the organizers can give a case scenario, then probably the remaining people can answer and others can support. If everybody feels sleepy, we can wind up the thing. Just a ad hoc, maybe ad hoc case scenario.
Yes, sir.
Yeah.
Niranga, are you there?
Just,
Yes, sir. I'm here, sir.
You're okay with that?
Yes, sir.
So, 45-year-old gentleman coming with a sudden onset of penile pain after vigorous sexual intercourse with detumescence.
Yes, sir.
You have been asked to see this patient in A&E. How would you proceed?
Yes, sir. Here my main working diagnosis is a penile fracture, sir. So I will go to the patient, make sure he's pain-free, give adequate analgesics, and take the necessary blood for investigation, make sure he might be a surgical candidate within the next few hours. So in history, I will assess this typical history of having a sexual intercourse where he will have this popping sound, cracking sound with loss of erection. And usually it occurs in a peculiar sexual position, and when it crushes along with this symphysis pubis of the groin or with the groin area when the penis is crushed. And on examination, I'll make sure whether there's a possibility of asking patient whether there's a passing of hematuria, and thinking of possibility of association of a urethral injury as well with the penile fracture. And there will be a typical sign of this engorgement of the penis, and there will be superficial hematoma. On palpation, I might be able to palpate the defect in the tunica albuginea where the fracture site, and I will explain the condition of the patient and make sure the patient is offered urgent surgical exploration and repairs.
Okay. Sorry, sir.
Go ahead, please. Yes, please. No, go ahead.
Any imaging you will consider?
If the facility is available, the ideal one is the MRI of penis, but the ultrasound scan can be one, but it's not so sensitive enough, sir.
I would.
What are the differential diagnosis you would consider, Niranj? Any other diagnosis that you would think of, or is it just penile fracture? That's it.
There are some differential diagnoses like superficial hematoma without a fracture, sir.
From where is that hematoma from?
That can be from this dorsal venous plexus, sir.
What was this classical appearance, the sign? What do you call that?
It's get the shape of a brinjals.
Aubergine sign, isn't it? Aubergine.
Yeah.
Yeah. Okay, is it very painful? So your initial management will include any analgesics and things like that? No.
With the expansion of hematoma, there can be a pain, sir. But usually patient lies comfortably, sir.
I want to ask from the expert panel, what is your opinion about imaging, sir?
Ajit?
Yes, at least I think ultrasound, if it is available, would be good. But I think classical history with the classical hematoma formation, then the sudden detumescence, etc., would, in the absence of imaging, also be suitable for proceeding to surgical intervention. However, there is no major urgency, unlike in priapism, to run in and do any surgical procedure. So if there's a bit of time to go ahead and get the imaging sorted out, I think that is reasonable to do this as a reasonably urgent procedure, but not during the night time, etc.
Is intercourse essential to have penile fractures?
No, sir. There can be habitual patients who are doing this penile bending can have penile fractures, and there are cases of vigorous masturbation causing the penile fractures.
Yeah. Luckily, we don't have it, but some other countries, they have this acute bending of erect penis, done as a habit, as you said.
Sir, actually, I had one patient who had that thing recently, 18-year-old. He wanted to correct the bend himself and got fractured.
Right.
And as Ajit sir said, this is not an urgent operation. We can do in the next available list. And imaging, as I said, if availability is there, we should do. Advantages would be even decide the incision to avoid, degloving of the penis. If we know the place possible, we can, plan a penoscrotal incision.
Is there a place for antibiotics?
So if the fracture is associated with urethral injuries, there's a need to do it within 24 hours or something.
Yeah. Yeah, I think if he is in retention, he can't pass urine, there's blood in the meatus. Then, of course, you have to treat it as a urethral injury as well. So maybe a suprapubic cystostomy and antibiotics will be important.
And Niranga Neville sir asked about antibiotic, need of antibiotic.
Yeah.
Yes.
What is, yeah. What do you think, Niranga?
We can start on empirical antibiotics, sir, to prevent the risk of infection and translocation of bacteria from the urethral tract, sir.
I suppose so. Agree.
And Niranga, which part of the penis fractures most?
Tunica albuginea, sir.
No, which part? The ventral, dorsal, proximal, middle?
It's the proximal part of the penis, sir.
Dorsal surface and proximal.
Yes. As sir said, that is the part because that is the thinnest tunica albuginea.
Just to add one thing, as for the trainees, now in the UK, some centers are really strict on not doing this imaging thing. As we have discussed, I'm just adding, the center I work, they clearly say no imaging, like 100%. Say they go clinically and go for surgery. So depends on the place you work also, like when adding things.
Yeah.
Hello?
Yeah.
The classical history and physical science, I think sometimes the investigations may be, imaging may be superfluous. So I agree with that, to go by clinical findings rather than, because you need these things come in the night, and then sometimes some places might not have small part ultrasound probes. So rather than waiting for that, better to go clinically. Yeah.
Shall we
Proceed,
discuss?
proceed.
Yeah, sorry, sir.
Yeah, you can proceed with the management. Okay. Oh, what do you
Yeah,
want to discuss?
management, how would you perform the surgery, Miranga?
I will palpate along the patients on physical examinations. If I can get the exact venal fracture site, I prefer to use this linear incision over the fracture site. Otherwise, I will use this circumcoronal degloving incision and go to the fracture site. I will thoroughly wash the fracture site and evacuate the hematoma. And I will debride the necrotic or unhealthy tissue, and I will approximate the this cavernous muscle and close the tunica albuginea. After that, I will put the patient on this the padding and crepe bandage. And if there's urethral injury, I will put the catheter and look actively whether there's associated urethral injury as well. And if there's urethral injury, I can repair it in the same dose. And after patient put in on a catheter and put in a cotton crepe bandage, I will assure the patient is on IV antibiotic and adequate analgesics.
What are the other structures you will be careful about when you are exploring? Say you have degloved it, and now you are exploring the hematoma.
Yes.
Any other structures you will be concerned about?
The frenulum artery.
That's far away. That's far away, isn't it? Frenulum arteries. What is there in the dorsum of the penis?
Dorsal veins, dorsal vein penis.
Is it only vein, or what else is?
Arterial complex.
There is neurovascular bundle, isn't it? So yeah, if the hematoma and the tear is closer to that, you might have to dissect it away from it before you go for repair. If you catch the whole thing, what will you end up with if you injure the dorsal neurovascular bundle, penile neurovascular bundle?
The patient might come across erectile dysfunction post-operatively, sir.
Not necessarily, no. Erectile dysfunction will come if you injure the sternocell arteries. They are far away. The dorsal nerve, what will happen? Which part will become anesthetized? Yeah.
Anesthesia of the glands, sir.
Yeah. So there will be problems in that. Not major problems, but I think that will be a problem in future. So be a little careful about the superficial dorsal neurovascular bundle.
What's the suture material you will use? What the needle you will use for repair the tunica?
Use this 3-knot white wheels.
No, not Michael, proline sutures. Proline 3-knot proline, round body, 20 needle, but around the small needle.
Yeah. Are we in agreement that we should use non-absorber sutures?
Yeah, non-absorber sutures are the recommended for the tunica albuginea repair.
Yeah. So, Anna, do you agree? Do you do the same way?
Bowles consensus says PDS, so that's a slowly absorbable one they use.
Yeah.
What is your experience?
Being a vascular structure, I use the finest, say, 4-3-0 proline when you are suturing.
Yeah, it's like vascular, isn't
because
it?
it's a vascular structure. It's like vascular surgery.
And the needle round body is very tough, no sir. Tunica is very tough, no sir. I mean, sometimes it's very difficult.
I think you can use a cutting one because the collagen fibers are arranged in such a way. They are arranged in a crisscross manner, so you won't get this tearing as a ring. You know that sort of a problem is not there. So I of course try my best to use round body. But if it's really tough, then of course you can go for a cutting. I don't think that makes much of a difference. But I think always go for a round body. Because cutting out refined ones, they cut the collagen, and if the sutures are falling in one line, it can tear one strip of the edge. So that is a problem of using cutting needle in theory. So
Yeah, that's what I think that I use reverse cutting needles because it is
right. Yeah, I agree. Yeah.
I also would use round bodies, just like
Yes.
mentioned. Yeah, I think that's straightforward.
any other things we have to add in penile fracture management? Nail sir, Ajit sir?
Yes. Will this affect in future? Suppose he ends up in a rectal failure. Will this affect prosthesis, insertion of prosthesis, this scar?
Ajit sir, do you want to comment? Usually, I don't think so, because we are reaming the cavernosum.
Yeah.
So if it is, I mean, if you can ream it, that's it. So the cavernosum hardly gets affected with the fracture. It's the
important is not.
Yeah.
Yeah,
It's
I think dilatation can be a little tricky. I mean, it potentially there may be a little bit of a soft area in the tunica at that point. So there may be a, I mean, unless one is careful, because you tend to go laterally when you dilate. So you can maybe perforate through the tunica at that point. So I think one just needs to be a little careful when you dilate, that's all.
I think it's the timing. I think it's just time it in such a way that the tunical scar is well mature and healed.
Yes. Absolutely. Nirangi, is it an option to leave and do nothing also? Or is there evidence to say that it is better to operate, or what do you think?
It is better to operate because it can cause this fibrosis healing and next curvature formation in the subsequent direction.
Yes, yeah, I agree with you. There is a body of evidence which suggests that people who are operated versus not operated, those not operated will do
mandatory.
I think trying to prevent erections is almost an impossible task, isn't it? I don't know what about you, your experience, even in, I think, your urethroplasty patients or whatever.
Yeah, I think that doesn't affect it as long as you have sutured it properly. I think the erections might not cause much trouble, really. That's one little worry that I think if you're using cutting needle close to the edge, there's a possibility of, rebleeding. But otherwise, I think if your suturing is sound, as Ajit said, I think even urethroplasties, erection should not affect it if your suturing is good. Really. Do we have any other case studies or trainings?
Do we have time to discuss, Ajit sir? Another maybe 10-15 minutes. That okay with you, sir? Thanks, sir.
Yeah, go ahead.
Yeah, Niranga, are you okay, or
Yes, sir.
Shall we irritate another volunteer?
Another candidate that you can
please. Yeah, another candidate.
They are all facing for the exit exam, so I think it's a good opportunity.
Yes, definitely, sir.
Nabil is there, sir.
Nabil? Okay. You have been called to see a patient in A&E. He is a 34-year-old gentleman whom you have prescribed PDE5 inhibitors 2 months back. Coming to ED with sustained painful erection for 18 hours. How would you proceed?
Yeah. So when I call, I go to and see the patient in the ETU, where I will assess the patient. Initially, patient will be in the pain. I will reduce the anxiety and the pain, and I will assess the patient after discussing the history regarding this. Patient was using the phosphodiazide inhibitors, and the patient will be in the erect penis. So in a shy mood, I will with the Jepron, I will assess this patient, and where mainly the arterial vein occlusive clinical diagnosis most towards the vein occlusive who was used as the phosphodiazide inhibitors rather than the arterial bypass like in AV fistula, like things like other priapism, which is a semi-rigid tumescence. Here may be a very rigid tumescence will be there, and it will be a painful, and patient will have then I will consider with that I will come to diagnosis of priapism, and the long lasting it's more than for 6 hours, and with I will discuss with the patient the probability of the erectile dysfunction and the risk of the failure of after this procedure. Even there are procedures which can be done, but there will be a failures of the erectile function. And immediately I will what will consider is the ABG, where I can do the erect penile puncture through the ABG and assess this arterial blood or venous blood. Mainly the more towards the hypoxic bloods will be there, low pH and acidosis that will be there, more suggestive of the veno occlusive this priapism, which then I will come to with the do the immediately intervene with the aspiration techniques, which I can do with the 9 o'clock and 3 o'clock position with the penile block injection at the same site. Usually the aspirate and with a large bore needle. Some people use in butterfly but cannula, but the large bore needle where I can use it and aspirate. And if it is not settling with, even I can induce with the no irrigation techniques. And with the continuing irrigation techniques, I can consider the phenylephrine injection, phenylephrine. Even some centers we can still using to reduce the this priapisms to reduce the tumescence. And then if it is not settling, I have to consider the patient have other options as the surgical options, where I can do the Winter's procedure or distal bypass or the proximal bypass whenever the necessary, with after discussing the patient possibility of erectile dysfunction. Hello, sir.
Yes, go ahead. Yes.
Yeah, then usually that after initial procedure is not settled, and I will do the Winter's procedure is the main. I will puncture through the 11 o'clock or 1 o'clock procedure through the taking to the theater and cleaning procedure under the penile block. I can do the Winter's procedure, where I will puncture through the glandular glands penis to the corpora, targeting towards the corpora, and with the large cut with the 11 blade, where will which I can screw it and open it and close the distal lid, and where I can bypass the bilateral side of the corpora with the glandular, it means glandular glands penis, then which will reduce the penis tumescence. Or if it is not settling, I have to consider the proximal bypass techniques, where the saphenous vein to the corporal bypass, or it may be a corporal bypass. Those techniques can be used. That is the techniques where I will consider, but all the techniques have the importance and the erectile dysfunctions with the long run. And I have discussed with the patient and tell regarding the pros and cons of these procedures.
Okay, if I may interrupt you, how many times will you aspirate? When will you give up?
I can try if all this case scenario is almost 18 hours. Mainly 6 hours where the targeting the priapisms. This one may have the risk of developing erectile dysfunction and the risk, other thing, success of this procedure also will less with this time period when I consider. So the aspiration, I will try with the immediate setup when I am attend to the place, and if multiple aspiration will make it multiple aspiration, not a single aspiration. In multiple puncture site or the 9 o'clock, 3 o'clock sites, and multiple in the same site, I can do that. The proximal
What's
to
the rationale between? What's the rationale of puncturing it in several positions? Is there a rationale for that? Or can you just aspirate from one side?
Yeah, one side, but other side, sometimes irrigation to continue, I will proximal and distal, I will target one side to irrigate if it is really the same side.
Will you aspirate both cavernosa or one cavernosa?
I will aspirate one cavern. Initially, I will try with the one side. If usually even one side, because the import risk of sometimes it will settle, because one thing is importance risk if you do the bilateral side. Other side,
are you sure you have evidence or experience to say that if you
not the importance, mainly the risk of reduce the fibrosis and ischemia. With the one side is enough to reduce that the ischemia and fibrosis.
Right. I don't think aspiration has anything to do with the final outcome of ischemia. Ischemia takes place whenever there is priapism itself will lead to cavernosal ischemia and fibrosis. That is the pathological process. So, why is it important to differentiate between high flow and low flow priapism? Those are the two words coined in the literature.
Yeah.
High flow and low flow. Yeah.
High flow is a recurrent one, usually self-limiting one, which can have semi-tumescence, which will not cause ischemia.
Yes.
So
secondary to how do you get high flow?
Usually the penile trauma, previous history of penile trauma, and it's causing the shunt, which is the high flow with the arteria fistula unnoticed, which can cause this high flow erectile preapism. There's usually semi-tumescence rather than compared to the rigid tumescence in this low flow one.
So why is it important to know the difference?
Because
what will happen if you aspirate a high flow priapism?
Yeah, high flow that will not settle.
If you aspirate, what will happen?
The continuous bleeding and hematoma formation, and the risk is high because already the flow is continuously there, slowly. Whatever the flow.
So when you are aspirating, can you differentiate whether it is a low flow or high flow?
Yes, one thing ABG or the color of the fluid.
Yeah. Rather than waiting for ABG to come, if it's bright red, give up immediately. Don't keep on puncturing. You can aspirate the whole blood volume if you want to. Okay.
Yes.
So it will keep on filling.
Yes.
We have done rarely this mistake. Right. So so that's one thing. ABG is also confirmatory.
Yes.
Okay. So right. So any other questions about aspiration and injecting metariminol or phenylephrine vasoconstrictors? What is the place? Do you routinely do that?
Usually, I have I have not practiced that. I have not used it, but practically they have can be used. But whenever the aspiration success rates are less, even with the phenylephrine, its additional benefit is questionable.
After aspiration, is it important to apply compression or pressure?
I'm not sure, sir. Not sure. The compression will be beneficial, but I'm not sure, sir.
Yeah, it's dangerous. Okay, so try not to do it because you have the tendency to apply some pressure bandage or around the penis or compress it after aspiration to keep it, prevent it from getting filled again. But that will lead to skin ischemia. So because of that, try to avoid it. Okay. So when will you decide to go ahead with winter eBOHO or winter procedure?
if it is even 12 hours, it means it almost if it is not success, if it is the proximal the respiration technique and this continuous irrigation, I have to consider immediately. I can consider the Winter's procedure.
Just spend a minute taking me through the procedure. Winter ever it's called. Yeah.
Yeah, I can under penile block, I can do in 2 o'clock and 10 o'clock. Sorry, I have mentioned the 1 o'clock and 11 o'clock. The 2 o'clock and 10 o'clock positions where I can target it through the glandular peen. The gland peen is towards the corpora. We are targeting towards where I will keep the blade in a transverse manner and keeping towards the vertical. While I introducing it, I will turn it to the vertical.
What is the scalpel you will use?
11 blades.
Yeah.
11 blade. So with the turning within the system, within the cavernous this glandular tissue, I will make it the channel in between the glans penis and the corpora cavernosa blood vessels. The filling system, so it can empty through the glans penis system.
Unilateral or bilateral?
I will do the bilateral.
Okay. And then will you close the skin incision in the
glands?
Or not?
I will close externally. I will close it, sir.
Okay, right. So, any other questions from the panel? We are all sleepy now.
So this did you all mention that aspiration alone versus irrigation versus the phenylephrine or metaraminol? Are there evidence-based advantages? What do you feel, Niranga?
Yeah, I think early days we used to routinely inject metaraminol, but leakage into the systemic circulation can give rise to certain problems. So these are all vasoconstrictors. So now of course, I don't know whether there are any new evidence to show any of these things are of any use compared to aspiration alone. So because the cavernosa is more or less, compromised, and most of the time it is ischemic in many of these situations. So injecting these things will like beating a dead horse. So I think the time factor is the most important, isn't it, Ajay? Because if it is a late one, nowadays the tendency is to, the moment you get the detumescence, rather than going for any kind of bypasses even, consider for a penile prosthesis.
Yep.
So, but as you asked, I think this there's no big difference between injectables and just the irrigation or aspiration.
Yeah, what you mentioned is correct. I think the timing is the crucial thing in the early ones. But I mean, I'm just reading out some of the AUA and ESSM, the sexual medicine guidelines and their studies. They mention that aspiration alone versus irrigation saline, there is no difference. But apparently the injection of phenylephrine and other sympathomimetics, there is apparently a evidence-based advantage. But as you very correctly pointed out, I think the late ones that we see, whatever we do, we are just flogging a dead horse, and prosthesis is what their patient is heading for at some point.
I think if you can't get rid of the tumescence, of course, then we have a problem in our hand because we have no access to immediate reaming and prosthesis. So we have to get the tumescence out. So for that, we used to do in our unit the perineal shunt. But we hardly ever, only a couple of occasions we did the gray hack, where the saphenous vein is connected in the early stages to the dorsal vein. But the perineal shunt, I think we have done often. But that helps, when you open the cavernosum there from the perineum, that itself also is helpful in evacuating the clots there, blood, and then irrigate the cavernosa more easily than through a needle, actually. So if it is therefore detumescence, go for the perineal exploration and do a cross-conjunctional shunt there, just to get rid of the tumor cells. And at the same time, you can give a good corporal wash. So that is our experience. But now people argue against that also nowadays, because if you are planning for a prosthesis, having a shunt there and weakening the crus plura of the crus of the corpus cavernosum may not be that beneficial when you are reaming and try to place the proximal end of the prosthesis. So I think in late cases, just to we will be doing shunts only to get rid of the tumor cells. But it's not going to help much in preventing erectile failure.
Yeah. Any other inputs, sir? I mean, Ajit sir, Dr. Sahan.
I think knowing some of the dosages of, for example, phenylephrine, etc., may be important. How to prepare the dosages of at least one of these sympathomimetics which you are currently using in your wards. So for an emergency case, if they ask you at the vivas, you may want to show that you have done this, and what is the vial phenylephrine 10 milligrams ml, you dilute to 50 ml, then it's 200 micrograms per milliliter, etc. So half a ml of that would give you the 100 micrograms which you need to inject. So just be prepared for a viva, the dosages, etc.
Right. I think we have come to the conclusion. Okay, fine. In the absence of any further questions, I would like to thank all the expert panel. First of all, Ajit sir, Neville sir, as well as Dr. Sohan Pereira for their inputs, sharing their knowledge and experience. Further, I would like to thank all the speakers, Dr. Pragalatan, Dr. Niranga, and Dr. Nabil. I would like to thank my co-moderator, Dr. Nishanta Veerasinghe, as well. Because this andrology is unfamiliar and bit of unpopular for us in our part of the world, because we are not practicing so much andrology. But today's presentation, they have taken to the deep sea of andrology, and we had a good discussion as well. So hope we all gain something out of these presentation. And last, I would like to thank our sponsors, CIPLA, for organizing this Zoom platform. Thank you very much. Have a good evening and a nice weekend ahead.
Okay, thank you, sir. Thank you very much.
Thank you.
Thank you, Taha.
Thank you.
Good night.